Hi, good evening. Thank you for joining this live session. A couple of you had asked questions on the comment section, and I thought I'll have a quick review of nasolacrimal duct obstruction. So, it's a very common problem. It starts manifesting around 3 to 4 weeks of age. Remember that the babies do not produce tears in the first 2 weeks or so, and by the third week they start producing tears. Because the nasolacrimal duct is not draining the tears in the initial period, there is often blockage, and it's not uncommon. But if it persists, it is called the nasolacrimal duct obstruction. And this is how it manifests. A baby with VP eyes can be sticky mucus or it can be watery. And this is the anatomy. The lacrimal gland is present in the upper eyelid. It produces tears, and as I said, first 2 weeks there is no tears or minimal tears, and then it starts forming, and subsequently the tear is drained by the puncta into the canaliculi, take it to the nasolacrimal or tear duct, and that drains into the nose. So obviously any congestion in the nose aggravates this blockage. So if there is a pre-existing block, the drainage is obstructed more. We need to tell the parents that it's benign, and most of the time there is no infection. It may appear sticky because when the tears overflow, especially when the baby is sleeping, the mucus that is part of the secretions tends to stick together. So you may find yellowish secretions that stick in the lower part. If you clean, it goes away. So the ways to differentiate it from infection is lack of redness, and also when you clean it after the baby wakes up, it doesn't accumulate immediately. If there is infection, it tends to be VP even when the baby is not sleeping. So this is one way to differentiate. Obviously, if it's persisting and it becomes pus-like, we may need to treat with antibiotics for a few days. Eye drops should be adequate. But don't keep repeating the antibiotic drops if it is just the mucus, the child is not bothered by it. The treatment for it is just massage, and the aim of the massage is downward pressure on the nasolacrimal duct in the upper part, and when you release it, the blockage may release temporarily. So the index finger is placed over the superior aspect of the nasolacrimal sac, so this portion, and then moderate pressure is applied downward. The downward pressure may cause rupture of the membranous obstruction, but this is not going to be dramatic because many times the parents keep massaging for months together and it doesn't still relieve. So there is a narrowing of the tube, and with age the tear production reduces as well, and obviously the drainage becomes more efficient. So most of the babies do not need any treatment apart from the cleaning of this crusting and the massage. However, if the massage is not effective and it persists beyond 1 year, especially with tear overflow, as the child is growing up, you may need ophthalmologic procedure. It does need general anesthesia, and they do wiring of this or probing of this nasolacrimal duct, which is blocked. So depending on which side is obstructed, they may do it unilaterally or bilaterally, and the outcome is usually good. I have not seen many cases needing probing, probably just 2 babies or so in the past 20 years. So it's not a big number that needs treatment. So it's a fairly common problem which worries the parents, but reassurance is a mainstay. So this is about nasolacrimal duct obstruction, and I hope this part is useful. We will then move on to the next part, which is breast milk jaundice. So breastfeeding jaundice is where there is relative dehydration in the first few days. There is reduced milk production. The letdown has not set in it, and the baby has relatively reduced calorie intake. So this dehydration as well as reduced calorie intake may lead to increased physiologic jaundice. So remember that the glucose is needed for the glucuronidation process in the liver. So the conjugated bilirubin formation is reduced in these babies, and the excretion of the unconjugated bilirubin is reduced. And when there is reduced milk intake in the first few days, the stooling pattern is affected. The baby doesn't pass stools till the milk letdown establishes itself. And so this delayed passage of meconium, as we discussed yesterday, will also lead to delayed jaundice resorption. So breast milk jaundice, on the other hand, is related to factors in the breast milk that affect the intrahepatic circulation of bilirubin. So we discussed the bilirubin metabolism yesterday. I won't be repeating it. However, just remember that when the conjugated bilirubin is excreted in the stool, the glucuronidase enzyme from the gut bacteria, as well as the one present in breast milk, may break down and release the conjugation, and this unconjugated bilirubin keeps recycling back into the bloodstream. So the beta glucuronidase enzyme is present in the human milk to varying levels, and some others it's present to a greater extent, and these are the babies where the jaundice tends to be persisting. So this is one factor to remember. The characteristics which distinguish the initial breast feeding jaundice from the breast milk jaundice. So the suboptimal intake jaundice is the breastfeeding jaundice, what we typically say. Onset is just exaggerated from the physiologic jaundice, so 2 to 5 days, usually resolves by 2 weeks. So once the milk letdown is established, lactogenesis is established, this jaundice resolves. There is ongoing weight loss in these babies, which gives a clue that inadequate intake. You may have urates in the nappy, you may have a greater degree of weight loss as well. So it's commonly seen in less than 38 weeks, mainly because these babies struggle a little bit to establish lactation. Even though breastfeeding is natural, the early term babies may struggle to cope with the breastfeeding, and that's one of the reasons why the figure I showed you yesterday, that bilirubin more than 20 milligram is significantly more common in the babies under 38 weeks. It's also related to the liver maturation being slower. And these babies, because of the inadequate milk, are fussy and maybe feeding difficulty noted as well. Breast milk jaundice, on the other hand, the onset is later and it may persist for even up to 3 months. I've seen a few babies where it persists at a level of 10 to 12 milligrams at 3 to 4 months with absolutely no other pathology. In those babies, I just monitor the conjugated jaundice once in 2 to 3 weeks, and as long as it's stable and the bilirubin is coming down, I don't worry. Of course, we do the prolonged jaundice screen once a baby is 2 to 3 weeks of age to rule out thyroid problems, urinary infection, and so on as well. The baby tends to gain weight well in these groups. There is not a breast milk output deficiency. It's more about the beta glucuronidase, which causes more recycling. The stool output is good, the urine output is good, and the baby keeps waking regularly. So this is again a summary of the differentiating features, with physiologic jaundice, which is a little earlier than the breastfeeding jaundice, which is exaggerated due to the lack of milk output, and the peak bilirubin 3 to 4 days, in physiologic 3 to 6 days, a little exaggerated peak, and the level is higher as well, 5 to 12 in physiologic compared to more than 12 in breastfeeding. So there are some babies with breastfeeding jaundice who end up needing phototherapy if it approaches the level of treatment. And the total bilirubin drops to less than 3 milligrams by 1 to 2 weeks in physiologic jaundice and more than 3 weeks in breastfeeding jaundice. Because the peak is higher, the liver maturation takes longer to clear the load. However, in breast milk jaundice, the peak is by 5 to 15 days. The level often crosses more than 10 milligrams per deciliter, and the bilirubin drops only by 9 weeks on average, but some babies it may persist even longer. The incidence is very common in full-term babies. Physiologic jaundice in 56%. Breastfeeding jaundice is related to the rate of difficulty in establishing breastfeeding. So a similar proportion of babies would reach a weight loss more than 10%, so about 12 to 13%. And breast milk jaundice is not very common. It depends on the beta glucuronidase enzyme in the breast milk of the mother. So it happens in 2 to 4% of the babies. So it's not common, but it's not very uncommon as well. Of course, formula supplementing will reduce the breast milk jaundice, but the question is, do we need to do that? And definitely the answer is no, because as you can see in the previous slide, these babies are gaining weight very well. They have normal stools, normal urine, and are thriving. They sleep well, and supplementing any formula in a breastfeeding baby is not acceptable unless there is an absolute indication, like the bilirubin is approaching exchange transfusion level, or the parental anxiety level is so high despite your best efforts to reassure them. So bilirubin by itself is not harmful unless it exceeds a certain level to cross the blood-brain barrier. And so you can reassure the parents that this persisting jaundice is not going to harm the baby. Of course, you do have the stress of having to come to the hospital or the laboratory to do the test once in 2-3 weeks till it starts resolving fully. However, the benefits of breastfeeding will far outweigh any stress. So proper education of the parents, explaining that it's only because of some factor in the breast milk and the fact that the bilirubin does not harm the baby. You have done the baseline investigations which rule out conjugated hyperbilirubinemia or urinary infection or hypothyroidism. So show them all these factors and reassure them. So I think we will see if there are any questions. So there are no questions, so I think I'll stop the discussion, and thank you for joining. I hope it's useful.